series in the Health Equity Implementation Science Research Series. Today, we are honored to have Dr. Marshall Chin from the University of Chicago, who will be presenting research on guiding principles to address the impact of algorithm bias on racial and ethnic disparities in health and healthcare. We are also delighted to be joined by an expert panel, including Dr. Sachin Shah and Dr. Heather Whitney from the University of Chicago, and Dr. Juan Rojas from Rush University. Very good. So I'd like to start off and thank everyone out in the front lines, healthcare workers and in the community who are fighting the good fight for health equity across metropolitan Chicagoland today. Thank you for your heroic work. I'd also like to thank our leadership and the program directors and director of the Outcomes Research Network, Dr. Susan Fisher, for supporting this seminar series. So our seminar series has multiple objectives that we achieve, what we hope to achieve as a result of the conversation of the great lectures and the panel. We hope that this leads to collaborative work to advance health equity in our health systems, in our communities, and to promote equitable care and outcomes through policy change, as well as advancing translational science. That is, we hope to inform policymakers from this work that could lead to further dialogue and reform. We want to support clinical investigators across the board, foster collaboration in team science, and connect researchers across our region. We also want to provide some outcomes research showing improved outcomes and equitable health in our communities over time. Next slide. Oh, and I'd like, sorry, back up, introduce my co-pilot, Rachel Brewington, who is the facilitator. She's the administrative assistant for outcomes research. And I'm Sean David. I am a family physician scientist and program director for translational science and outcomes research network at Endeavor Health, and a clinical professor at the University of Chicago. Okay, now we can go to the next slide. Learning objectives of today's seminar are to identify sources of bias in healthcare algorithms, to understand guiding principles to address bias in healthcare algorithms to advance health equity, and to consider solutions for preventing, mitigating, and addressing bias in healthcare algorithms. Also, we're a participant in the Institute for Translational Medicine, our NCATS-funded Clinical and Translational Science Award. And through this seminar series, and particularly today's topic, it addresses really all 8 of the NCATS translational science principles for creativity, innovation, unmet needs, generalizable solutions, cross-disciplinary team science, efficiency, bold and rigorous approaches, diversity, equity, inclusion, and belonging, and bounding crossing partnerships. So this is a really archetype for what this seminar series is supposed to try to cover in terms of translational science competencies. Next topic, or next slide, please. Okay, and I'm going to hand this over to Rachel to talk about CME.
Thank you very much, Dr. David. Hello, everybody. To mark your attendance today and claim CME for today's session, text the SMS code to the number listed on the screen. For this live activity, the University of Chicago Pritzker School of Medicine offers a maximum of 1.5 AMA PRA Category 1 credits. Physicians should claim only the credits that match their participation level. Other healthcare professionals will receive a certificate of participation. If you're interested in how these certificates apply for AMA PRA Category 1 credit from ACCME accredited organizations, please check with your professional licensing board. The CME flyer is attached to today's calendar email and will also be emailed to you along with more instructions on how to retrieve your CME credit after the seminar. During the webinar today, you'll be muted, but feel free to ask questions or share comments using the chat functions at any time, truly any time. Just remember to consider your audience when posting, and if you have something to contribute to the discussion, please make sure to address it to both panelists and attendees so everyone can participate.
Thank you, Rachel. So an overview of today's seminar is following the introductions, we'll have our presentation. And as Rachel mentioned, we want participants to put plenty of comments and questions into the comment section throughout at any time, so we can return to those later during the Q&A. and the expert panel. And that will start about over the next 5 to 10 minutes. Then we'll have a 5-minute Q&A session at the end. And then we will introduce our expert panel more with a bit more detail, and then go through some discussion questions during that time with the panel. And then we'll have some closing remarks. So it's my honor to introduce our guest lecturer, Dr. Marshall Chin, who is the Richard Palillo Family Distinguished Professor of Medicine and Associate Chief and Director of the General Internal Medicine Research, and Director of the Chicago Center for Diabetes Translation Research, and Director of the McLean Center for Clinical Ethics at the University of Chicago. Dr. Chin received his bachelor's degree from Harvard College and his medical school at the UCSF in San Francisco, as well as a master's in public health from Harvard University. His major research is on improving shared decision-making among health professionals and LGBTQ racial ethnic minority patients. And he's led several investigations, many investigations on health disparities in diabetes care, in health centers serving vulnerable patients with limited assets, and in healthcare biomedical informatics. He also is a former president of the Society of General Internal Medicine and was elected to the National Academy of Medicine in 2017. So Marshall, welcome, and thank you for joining us today.
Yeah, thanks very much, Sean and Rachel, for the generous invitation to present here, as well as the opportunity to have this, I think it was going to be a fun discussion with colleagues and friends on the panel. So actually, first, a couple of corrections. That the very generous introduction. I'm a co-director of the Chicago Center for Diabetes Translation Research and an associate director of the McLean Center for Clinical Medical Ethics. I don't want to upset Peter Angelos, who's like the director now, new director of the McLean Center, but thank you for the promotion. And so here is the title slide here. Yeah. And so I was invited to speak with you all today because of the article that's at the top of this slide. It came out in December 2023 in JAMA Network Open, and it is the title that was the title of this particular session. This was published just in December, and it's received a fair amount of attention already. It's about 17,000 page views, an altmetric score of 112 on social media, which is pretty good. It's been cited already 4 times in the past 3 or 4 months. And then also in January of 2024, the Biden administration, they published a White House fact sheet where they want to publicize a number of their administration's efforts because examining AI is one of their major priorities. And we were one of the 6 or so different things that this White House fact sheet cited. So it has attracted a fair amount of attention, even rapidly over the past 6 months. And so I know there's probably a variety of folks on the call, ranging from people that know a lot about this area to people where this may be brand new. And we're going to try to design this session to be of value to both groups, whether you're a newbie to this field or know a lot about it. And so just some foundational information that a healthcare algorithm, we're defining that as a mathematical model used to inform decision-making. It can be used for diagnosis, treatment, prognosis, risk stratification, triaging patients, allocating resources in your organization. Probably most of the people here are familiar with traditional statistical regression models, which look to define a relationship between some type of predictor variables and the outcomes. That's pretty intuitive. On the other hand, artificial intelligence and machine learning models, they're more of a black box in the sense that they look at a large data set and they learn inferring relationships in this big data set. It's not as intuitive as like these graphs we look at, for example, predictors and outcomes in a like linear relationship, for example. And so there is this sort of non-intuitive black box problem with AI machine learning. I would point out, though, that all the principles we're going to talk about today apply also to the more traditional statistical regression models regarding potential biases and potential effects on health equity. I think AI, though, has attracted more attention because it seems mysterious and not transparent. some of these principles are perhaps even more important for these AI models. So if you haven't seen it, there's an old Tom Cruise movie called Minority Report, and that's Eber and Roper, I believe. Two thumbs up, way up is a masterpiece, and I do think it is a good movie. And the basic premise of this movie, which takes place in the future, is that Tom Cruise is part of this police unit, and it's a very special unit because they have a system for being able to predict ahead of time when a crime is going to be committed. And so this unit will basically then intervene, and before the crime is committed, they arrest that person. So on one hand, pretty cool that you're basically preventing crime. On the other hand, kind of scary in that it's all predictive. And so you're basically predicting when you think a crime's going to occur and arresting that person and putting them behind bars before they've actually committed the crime. So that's science fiction, but really that's like this in some ways it applies to today. I think like the best like lay introduction to this I've seen is this book by Kathy O'Neill called Weapons of Math Destruction. A pretty scary book where she basically takes you through like life, basically sort of actions throughout the life course that affect us going through life. So if we are applying to college or applying for a job or applying for a mortgage for that first home, or we're trying to get a credit score, or if we have some type of involvement with the criminal justice system, the ways that these algorithms can potentially affect us and bias against us. So what is bias then? So an unbiased algorithm, patients with the same algorithm score classification have the same basic needs. So you have an unbiased algorithm, it's basically a fair scoring. So you get the same score, you truly do have the same basic needs. However, in this O'Neill book, she documents in a scary way, like in all these other fields where in some ways other fields are ahead of us regarding how they've looked for bias. There's strong evidence for documentation for bias in housing, banking, education, healthcare, and the criminal justice system, which is one of the scariest examples. And you've probably seen a lot of this literature more recently in healthcare. And maybe the two most famous examples are kidney function, estimated glomerular filtration rate. So very common test done by clinicians very commonly, and actually giving higher function to Black patients than white patients. The practical effect is led to delays in organ transplant referral for Black patients because they are assigned an erroneously good estimate of kidney function. Maybe the most famous example is this paper by Obermeyer et al., where they looked at a proprietary disease management program that would assess eligibility for these chronic disease management programs where patients would get more services and more oversight. In this particular proprietary algorithm, it was like over 100 million patients which were affected in the US, a lot of patients. And they found that Blacks had to be sicker than whites to qualify. And the reason was when developing the algorithm, the people who developed it use resource utilization or money spent as a proxy for health status. They thought that, well, if you look at the amount of money we spend on patients, well, that's their proxy for health status. The problem is that because of access barriers, it led to less resource utilization for Black patients. So at any given level of resource expenditure, Blacks in practice had higher disease severity. They were sicker. So an example how things can go wrong if you have like the wrong measurement for your outcome. So I'm going to first go over like sources of bias in this whole process, and then spend most of the time on the actual paper. And shout out to Heather Whitney, who's one of the panelists. She has the most detailed, rigorous classification scheme I've seen for bias. I think like her scheme has like 30 different types of bias. I'm going to go through a simpler schema, but Heather is like the expert for like if you want the deeper dive in terms of some more comprehensive outlining of sources of bias. The senior author in that particular paper is Mary Ellen Geiger, who's from the University of Chicago Radiology. So the simpler system comes from an earlier paper, 2018 paper, Ensuring Fairness in Machine Learning to Advance Health Equity. So this is kind of interesting. Like, so for the investigators here, you never know which of your papers are going to hit. And so of all my papers, this is my fourth most cited paper, even though it came out fairly recently in 2018. So it's an example of, because it's an important topic, and this paper came out a little bit ahead of the curve, then it's been highly cited by people working in this area. And so actually, again, this is an aside for trainees or students or early investigators. I think a lot of people make the mistake of sort of settling on a research topic because they get nervous, and they basically pick a topic because they start getting nervous about not deciding what they're going to do early on. Whereas I would argue that the decision on what you focus on to study is one of the most important things, because you want to basically find some important topic that's understudied so you don't have much competition. And what happens then is you pick a good area, and this being one example. So JC is going to be example, and Heather are examples of a couple investigators who are still getting in fairly early in this area. It's just so much easier when you're picking an important topic which is understudied. So, and this particular paper, they're mostly Google people, and the way I got involved was Michael Howell, one of the middle authors. He used to be the chief medical officer at University of Chicago, and so he invited me to participate in this project shortly after he joined Google. So I learned a lot from the Google folks, and it really is the first two people in this paper, Rash Kumar and Hart, who really drove this paper. They did a great job in the paper. So one of the things we have in this paper is an example, and so this is actually a local example where the University of Chicago, the data analytics group, the business people, they tried to design an algorithm that would predict who would have a short length of stay. The reason was they thought that, well, if they can identify who has a short length of stay, they can direct even more case management resources to those people to make sure they leave the hospital on time. The intentions were good because from the hospital's perspective, well, you free up a bed, you can serve another patient, you can then have more of a revenue stream. And then from a patient perspective, the hospital is a dangerous place to be at. So, once you're ready to leave the hospital, it's in your advantage to leave that hospital, which is a dangerous place as a whole, and go home. The analytic group, they did a basic model, and then they did a second model where they found that if you add the zip code where the patient lived, it improved the predictive accuracy of the model. But what it found was that it was the more affluent, whiter zip codes that predicted the shorter length of stay. So if they actually implement this model, it would have led to the perverse result of more case management resources being allocated to the more affluent, whiter patients, who are the people that really you wouldn't think would be an appropriate group to give even more resources to. And to their credit, like when the data analytics group found out this would have been the results, they were concerned, and it actually made them look at this whole process of developing and implementing the algorithm and thinking about where does equity sort of fit in this overall process. So they've actually become now one of the leaders in proactively using analytics algorithms to advance health equity, as opposed to it, in this particular case, if it had been implemented, it would have worsened health equity. Okay, so again, like Heather's paper has like the definitive sort of like classification scheme for biases. I'm just going to give you like a simplified version, just to give you a little bit of background. So biases can come from either the development of the model or the deployment of the model. And so this is a figure from the model, and we're going to go through it in more detail one at a time. See, so the left-hand side of the model is model deployment. Oh, sorry, model development, meaning the design and the data you use. And the far right-hand side is the model deployment, and divide it into patient factors and then how clinicians interact with these models and biases. So first, we're going to talk about model development. So I'm going to blow up this particular part of the slide. So you see at the top there, these technical terms, features and labels. You might think of features as like your covariates, the different characteristics you're looking at, which might be associated with then the so-called labels, or in some ways the outcomes that you're trying to find for your model. So in the Obermeyer example, that was an example where there was label bias because they use resource utilization as a bad proxy for health status. Another example would be, so the clinicians here, something like the diagnosis of depression. So there's evidence showing that the traditional ways we use, criteria we use for depression, tend to diagnose a depression in people of color, where a number of the minoritized racial ethnic groups, they don't use as often some of these sort of emotional sort of like criteria of like depression and feeling sad that are more prevalent in white groups. And so that there's some evidence that people of color compared to white patients will more likely have a higher prevalence of somatic symptoms, so physical symptoms. So if we use like traditional psychiatric criteria for defining depression, we're going to underdiagnose people of color for depression. If you look in the far left-hand part of this diagram, so this is again some of the features. So minority bias would be, for example, if we underrepresent minorities in the data set. Informativeness data. So for example, we're trying to develop an algorithm to diagnose melanoma in a Black patient. If we have a data set that's primarily like pictures of white people with melanoma, that could have a bias regarding how informative it is for diagnosing melanoma in Black patients. Cohort bias, that's for example, taking like what is the easily available cohort as opposed to being more granular in their look. So one example would be like, if we just like look at race ethnicity as opposed to looking at intersectional features like class intersected with race ethnicity, or another example would be like if we look at an aggregate Asian category, then that tends to fit the model minority effect, because then you have like some of the immigrants that were prioritized in the 1965 Immigration Act, which gave priority to professional classes, people with skilled classes, a lot of like East Asian and South Asian Indian groups. That's gonna like overwhelm the numbers. For example, you look at like all disparity statistics, Southeast Asian immigrants. So for example, some of the immigrants from the Vietnam War, Cambodians, and Southeast Asians tend to do worse on the health disparity figures, as an example, or the aggregate numbers will, for example, bias against like some of the service workers you see in Chinatown who are low-wage workers that oftentimes don't have health insurance, and will have worse numbers. Missing data bias. So a classic example, very common, would be like if you have good insurance, you're going to be more likely to have a full set of data within like the Endeavor Health System or Universal Health System. Whereas if you don't have health insurance, you can have fragmented care. And so if you looked at just like a Universal Chicago data system or just an Endeavor Health System, you're going to miss patients who receive care across multiple emergency departments, for example, or who have visits admissions to multiple health systems because they don't have good health insurance. So this is now this right-hand box. So this is biases affecting patients. So if you look at we'll start with the far left. So agency bias is basically meaning you're not at the table. So underserved patients without political power oftentimes won't be at the table as these algorithms are being developed, deployed, and monitored. Or could it be informed mistrust? So for example, if you come from the South Side of Chicago and you don't have mistrust in the University of Chicago as a system because of the historical examples of bias and discrimination, maybe you're not going to be as willing to supply information in the development of an algorithm, leading to lack of information and representation in the algorithm being developed. Or privilege bias, it could range from like algorithms, I wouldn't be surprised, for example, are not being developed for sickle cell anemia, as opposed to algorithms that benefit a more affluent population. Or if there's a digital divide and these algorithms are applicable to someone who has access to the internet at home. There's a couple examples of privilege bias. This last one is kind of nefarious. It's clinicians interacting with these algorithms. So it's a reminder too that you could have a pristine algorithm, but if then clinicians interact in ways that don't introduce other biases, it's an additional, again, source of bias. So automation bias would be if clinicians blindly follow an algorithm, even though it's known to be a biased algorithm for the reasons we talked about before. Or you can have the reverse problem that clinicians may know that an algorithm is biased, so then they will just automatically dismiss it. So for example, like one example is something like these early warning systems that designed to detect a patient in the hospital who's on the verge of crashing, and that might benefit from intensive care unit surveillance. So if, for example, physicians find that, well, we know it's biased against African Americans, this algorithm, and that therefore we're gonna ignore this algorithm because basically there's a lot of false positives and alert fatigue, you could then have this perverse problem where then this just ignoring the algorithms that identify African Americans, that it may not be a great algorithm, but it still does something in terms of identifying African Americans who will crash. And then allocation discrepancy is that if because of the bias algorithm, then the decisions of the clinicians then will lead to a inequitable distribution of resources. So it's, again, kind of sobering how these biases can seep in at any different part of the algorithm process. Okay, so that's, and then the whole model is how it fits together. Oh, training, the one in the middle, this training skew, serving skew, that would be, for example, and so an example here is like Epic, where there's a lot of these algorithms that are built into Epic, which may not have been developed on algorithms that are similar to your hospital or institutions. For example, if you're a safety net serving institution. So again, it's sort of a nefarious introduction to bias. So shout out to JC Rojas, who's on this call, and Sonia Machny, part of this group here. If you're looking, they had a couple of papers published in Chess a couple of years ago. So if you're looking like for your first introduction to these terms and all, I'd refer you to Sonia's article, the Equity Challenges article. Short, concise article, very nice table. So it's a great way to get like an introduction to the basic terms here. JC's article sort of builds upon Sonia's and has a deep framework. And well, I'll show a slide at the end, which has the framework, sort of an example of how do you put it all together. I put out here too, like this was a cool example where the authorship group, they were academics, they were operations people, and they were people from the diversity group. So Scott Cook and James Williams are people from our DEI J group here at the university. Craig at the time was involved in like the operations on the medical operations side. John was in the data analytics group. So it's a nice collaboration. And if this is one of these interdisciplinary fields where I think to do it right, you got to have the academics, you got to have the operations people, and you need to have the diversity, equity, inclusion experts. Okay, now last 15 minutes of my session part on the actual article. So the background is that Congress requested this study, and there were 4 federal agencies that got involved. The 2 drivers were the Agency for Health Research and Quality, and then NIH. One of their institutes is the National Institute on Minority Health and Health Disparities, so they were heavily involved, and they were representatives of the other 2 groups on the committee. There was a 9-person diverse external expert panel. So I was one of the co-chairs of this committee. Another person that you may know from her time at University of Chicago was Maya Hightower, who used to be the chief information officer. Session knows her. She was on the panel. She actually originally was going to be the co-chair, but because she has this private equity company, they thought that was too much of a conflict to be a co-chair. So she became a regular panel member, and they asked me to be the other co-chair because of that conflict of interest. Our process was that we looked at evidence, and so there was, in particular, a UPenn evidence-based group was contracted by ARC to do a review of the existing algorithms out there, and they actually have a revised paper. It's now in Annals of Tournament Medicine, just came out, so that's their definitive paper. The challenge, though, is that because of proprietary issues, the proprietary groups have like no particular interest in sharing their algorithms and all. So what's available in the existing literature is just the tip of the iceberg regarding what's actually out there in the literature. The other thing is that the review that would have helped us, that they didn't do, that we ended up having to do ourselves, was then a review of other groups looking at guiding principles. That was actually the most relevant thing that would have helped us, but that wasn't in their scope of task for their review. Because so much is unpublished, we had 2 days of stakeholder panels where a variety of folks from industry, the community, academics, et cetera, gave their perspectives on where the field was at, because so much of it's not published. And then we specifically built in a public virtual meeting to get feedback from the panel and a panel of community folks, as well as open comments from the public. And then this was a laborious process where there were tons of drafts of this. It took a heck of a lot of time. So here's the key figure from the paper, that if you look at the middle, you see that health and health equity for patient communities is the guiding part. The middle part are these phases of a life cycle of algorithm. So JCP's paper has it also. The first part is the formulation of the problem. Second part, the data you use. The third part, developing the algorithm. Fourth part, deploying the algorithm. Fifth part, deploying monitoring the algorithm. The principles we'll go over in more detail. You see that bottom right, it just shows that all this is within the context of a society where we have a lot of structural racism and discrimination. At the very bottom, these principles can be applied at three levels. First, at the level of the clinician interacting with the patient. The second, at the level of the institution, i.e. like the Endeavor Health or University of Chicago. And the third is the society level, thinking about macro policy, macro economic policy also. Okay, principle number one is promoting equity in all phases of the algorithm lifecycle. And again, just sort of a foundational point for this paper or today, we use as equity, definition of equity, we're defining it as the attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally with focus and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, which includes systemic racism and the elimination of health and healthcare disparities. So there are some folks in healthcare, they tend to focus upon the very last part, the elimination of health and healthcare disparities. The other parts of the definition point out that there is this part about basically ensuring everyone has a fair and just opportunity to health, which includes specifically looking for the variety of baked-in historical and contemporary injustices, including systemic racism. So what this means then is that algorithms should be fair. We should have equitable outcomes. Bias should be detected, mitigated, and prevented. We need to monitor algorithms. And then very importantly, is pointing out that healthcare decisions, both human decisions as well as technical algorithm decisions lead to this. So some people, for example, think, oh my gosh, well, it's all technical, it's all AI, it's a runaway train. Whereas I think as you've seen from like the especially the bias slide, there's a whole bunch of human decisions all along the way that either can prevent, cause, or eliminate or proactively advance health equity. So there's a very human component to it. So principle two is transparency and explainability. So all relevant individuals should understand how their data is being used and how AI systems make decisions. Algorithms, attributes, and correlations should be open to inspection. So JC's team thought this was so important. You'll see that this is actually the thing at the very top of like JC's conceptual model figure, which I'll show towards the end. When you look into it, there are actually, again, technical definitions of transparency and explainability. So explainability, for example, has these 5 parts. The evidence and reasons for approaches, processes, and outcomes are there. The explanations are understandable to users. Explanations correctly reflect the system's process regarding the output. Information ensures systems only operate under conditions for which it was designed. Outputs only used when the system achieves sufficient confidence in its results. So there's a lot embedded in this simple term, explainability. So 3, authentically engage patients and communities, earn trustworthiness. So a lot of groups, they talk about, well, we're going to make the patient number one and communities number one. In practice, though, we often don't do it particularly good about authentically engaging patients and communities. And then this key part is incumbent upon us as systems to earn the trustworthiness of our patients and communities. So you see here, it involves patients being engaged in all aspects of the life cycle of the algorithm. So choosing the problem. So for example, if patients were involved from the beginning in the choosing of the problem, we wouldn't have had that problem with that University of Chicago example, which, it was found and stopped. But, that one about that would have led to more case management services to more affluent people. So involving patients in all aspects of the life cycle of the algorithm, patients must be aware of how the algorithm impacts their care. There's this term data sovereignty. So the ownership of the data is particularly important for indigenous peoples, so American Indians, Alaska Natives, and Native Hawaiians, for example, in terms of the ownership of the data and the implications there. And then very importantly, trustworthiness is earned through authenticity, ethical practices, secure data, and the timely disclosure of algorithm use. So the last 2, I think, are particularly important. So there's this issue of explicitly identifying fairness issues and trade-offs. And so the tricky thing here is that algorithmic fairness and bias issues arise from both ethical choices and technical decisions at each stage of the algorithm's lifecycle. And then all too often, they're 2 different worlds. The people who think about ethics, or ethics not even being on the radar screen for institutions, and the people who do the technical work of algorithm development and trade-offs. And we're already, you basically have to think about them simultaneously, and that's only going to happen if you have a diverse team that includes patients and includes the people that are technical experts, as well as the people that think about ethics and equity. So I'm excited. Like Heather is one of the people on the panel. She's currently one of the ethics fellows in the McLean Center, and so she has great technical expertise and also like now deep ethical expertise. And so we've talked about these distributive justice metrics. So for society, um, it's really important to not lose sight of the common sense metrics. So bottom line is clinical outcomes. Are there equitable outcomes? And then this issue of resource allocation. Do we have equitable allocation of resources? And in particular, this is idea of like distributed justice, or another term for it is like a universal or targeted universalism, where you aim for great outcomes for everyone, and then those who have more medical and social needs get more resources. And then there are these technical performance definitions, the metrics that my guess is that JC and Sachin and Heather will get more into. The challenge is that there are different technical definitions of algorithmic fairness, and these different definitions are mathematically mutually incompatible. What you're basically doing is trading off maximizing the accuracy of an algorithm across the entire group of patients, at the same time trying to minimize the accuracy differences among subgroups, such as different racial, ethnic, minorities groups across definitions. You mathematically can't maximize both. You have to trade them off. And so we recommend mitigating bias by having diverse teams. So we talked about then like involving patients. And then and again, I think the technical folks on this panel would be able to talk about some more detail. There are so-called algorithmic fairness toolkits that can help technically in terms of like improving equity. We also recommend thinking about algorithms and policies and regulations, looking at them through the frames of equity of harms and risks. So for example, those algorithms that they're at lower risk for big harm, you probably don't need to have as much oversight of, whereas something that would have potentially major impact on patients and potentially have major harm should have pretty rigorous oversight and governance structures overseeing them. And then we also talk about how, supposed to sweep things under the rug, explicitly identify what are these trade-offs among different competing values and options that you're considering, so there can be an open discussion about them. And so again, optimizing model fairness for equity in clinical outcomes or resource allocation using bias mitigation methods and human judgment. So this human judgment part is critical. Okay, 5 is also the other critical one, accountability, where the rubber hits the road. So individuals and organizations must accept responsibility to achieve equity and fairness and outcomes from healthcare or algorithms and be accountable. Organizations should establish processes at each stage of the life cycle of the algorithm to facilitate equity and fairness and outcomes involving all the different stakeholders. Organizations should have an inventory of the algorithms, and they should periodically screen for and mitigate bias. For example, like an algorithm that may be good now might not be good in 2 years if, for example, the patient population changes, the demographic mix of our patients, if we've learned more, the clinical judgment has changed, if we've learned more about like mitigating bias technically. And then sort of alluded this a little bit earlier, there's a number of different parts of the process where we could have oversight of prediction models, these so-called checkpoint gates, and JC's model has that, you'll see. Also, this point about oversight governance structure. So, what is the governance structure that's overseeing us all? And also there comes this issue, is it just, the data analytics group? Is it the wider University Medical Center? Is it a group that includes with the equal power sharing in the community? So you can see there are very important decisions to make regarding the governance structure. A lot of groups don't have any governance structure. And then making sure there's adequate investment in the data infrastructure and this whole process to make sure that we do this right. One point that the external panels brought out for this our NMHC effort was that it's not just regulation. So just don't go straight towards government regulation. Incentives are an equally important part of it. So we should align the free market incentives so it's in everyone's interest to do the right thing in terms of having these equitable algorithms that support equity and fairness. We need to support, for those persons and communities who have been harmed by unfair algorithms, they should be redressed. So yes, this is an important issue and a very interesting one in terms of, well, like, how do we identify who's been harmed and how do we go about making it right? And again, transparency is critical to identifying bias and inequity. We talked about how algorithms should not be deployed before validation on the impacted population. This is an interesting one. So under-resourced institutions. So, not everyone is an Endeavor or University of Chicago. So the panel talked about under-resourced institutions with limited technical capabilities should be supported in validation so that they can benefit from these algorithms. And then journals, funders, and research professional associations should identify standards for ensuring accountability for equity and fairness and outcomes from healthcare algorithms, for the algorithms to be published, funded, and rated as high quality. You may have noticed, for example, the JAMA network of journals, as well as like New England Journal, they're pouring a ton of resources into prioritizing AI papers. And my guess is they're going to do this in terms of what should their standards be in terms of a paper that is adequate in terms of the equity checks and all that they would pass their bar for being published in those journals. Okay, I'm going to end with a few overarching examples here. So one of the challenges is that the technical definitions and metrics of fairness do not translate clearly or intuitive to lay language regarding fairness or the so-called ethical, legal, social, and economic terms of fairness. So we already talked about the lay definitions. We talk about resource allocation, clinical outcomes, and then this is arcane world of technical performance metrics that don't align well. And we talked about this problem that even there within fairness metrics for performance metrics, there are different technical definitions which are mutually incompatible. So it's a mess, So that's why, again, one of these reasons why you need to have the technical people, the ethical people, the patients, the communities, and the clinical people at the table simultaneously to have these discussions. Which also means that there's no cookie-cutter simple solution. One of the things we say in the analyst paper is that we think, though, that if you have the right people at the table, you're likely to have a good discussion and process that will lead you to an appropriate answer individualized to your specific so-called use case. A lot of the problems happen right up front. And so, for example, the University of Chicago example, that happened because it's not outrightly egregious, but it sort of started getting to this issue of is your goal here health or profit? And again, it wasn't as clear cut in the UC example, but some of the current examples in the wider field are essentially health versus profit type of examples, as opposed to, I think we would all argue that equitable health and health care and health outcomes should be the goal here. My guess is the panel might get into some of this. There are implications for algorithm cut points. So I gave this example of the rapid response team for a crashing patient, where you do want to have a relatively low threshold for referring a patient to be considered for a rapid response team. At the danger, though, again, of this issue of the boy who cried wolf and sort of alert fatigue if you have a bad algorithm that's not good with positive predictive value. I sort of alluded to this early example. You don't want to have an algorithm that leads to having a lot of false negative skin biopsies for melanoma, although actually pointing morbidity on darker skin population. We talked about distributed justice principles. Couple minutes here. So people talk about these so-called food labels. So this is a nutrition label. Could you have the same thing for an algorithm that has some basic information talking about, well, this algorithm was developed on this population. It did these fairness checks. It had this these performance characteristics performing the accuracy, et cetera. So one of the challenges is communication, and that it's hard to explain probabilities and distributions in ways that people can understand. And again, the technical panel will have more expertise than I on this, but I've learned that there's this issue of this real data, and then it's synthetic data that a lot of these models built upon. It's hard enough to explain for real data than so-called synthetic data, which is not real data, trying to explain that. Assessing and explainability of applying a specific algorithm to a specific individual person, tough. And again, this is this legal informed consent, and I would argue that still a lot of the informed consent we do is legally okay, but not ethically okay in terms of patients truly understanding and providing informed consent. Though some of you may be following the Europeans who are ahead of us in this, one of the things they've had challenges with is then trying to balance between some of these safeguards we're talking about and then not handcuffing private industry regarding innovation. So it's an ongoing issue. And then the last one is very important. So we make this analogy to the patient safety field, where you try to, and this is very appropriate for this group, where you try to have sort of a safe culture where people feel that it's safe to report errors. That's the best way to quality improvement. So again, it's the same issue that there should be an ethical, legal, social, and administrative framework and culture that we create that redresses harm while encouraging quality improvement, collaboration, and transparency. So again, it's that tough nut to crack here. I will sort of briefly mention this. This is JC's model, so the model he led, transparent at the top. You see there's a very explicit process there for trying to root out biases, trying to figure out where those biases coming from, address them in all parts of the process, and then leading to health equity at the bottom here. And I'm sure JC will talk about it more. So this is like the second to last paragraph in our JAMA network, open paragraph. ChatGPT and other artificial intelligence language models have spurred widespread public interest in the potential value and dangers of algorithms. Multiple stakeholders must partner to create systems, processes, regulations, incentives, standards, and policies to mitigate and prevent algorithm bias in healthcare. Dedicated resources and the support of leaders and the public are critical for successful reform. It is our obligation to avoid repeating errors that taint use algorithms in other fields. And this is from an editorial that accompanied the Annals paper. I thought it was sort of a nice short quote here. It's kind of this paradoxical quote. The only solution is to apply to artificial intelligence algorithms the very thing they are designed to supersede, human intelligence. Some references for referral, and then my Twitter, the tagline there. So I guess we have some questions for me, and then we'll go to the panel, which I'm looking forward to. Okay, Sean.
Marshall, thank you for a really enlightening talk. And I'm going to hand the baton to Rachel to facilitate some questions. We do have some questions in the chat.
Thank you very much. Okay, thank you so much, Dr. Chen. Our first question comes from Susan Fisher. Regarding Dr. Chen's early slide on LOS and concern regarding initial step to provide more care to those predicted to have a short LOS, it seems that the AI model was developed based on current discharge data. That is, short LOS was working for patients with higher SES. It is perplexing to me that the first step was not to address those with long LOS.
Yeah, so it's interesting that it shows how it is so critical for the first step in the algorithm lifecycle to be the problem that you're looking at. You know, what's the goal? Because that's exactly the point, that it was the wrong goal. You know, I don't think that like the University of Chicago sort of entered it saying, "Oh, you know, we're going to find a way to put our Black patients at the end of the line here," right? But that's what it would have done, you know, if they had actually implemented it. Imagine if, for example, you had a more diverse team of decision makers where the group decided, well, we're gonna prioritize problems to look at, which actually would, in particular, focus first on the patients that are having the longer lengths of stay or are at risk for the worse outcomes, and trying to help improve their outcomes and processes first. You know, that happens if you think about the problem in a more equitable way, in a more mission-driven way from the beginning. And again, I think, like, to that data analyst group's credit, they've come a long way, and actually now we're doing great and are, like, I think one of the cutting edge groups now, thinking about how to do their work in a way that is more proactive about advancing of equity, as opposed to just accepting, you know, what may have been like the charge, and that would have taken them down this bad route if they follow through on it.
Yeah, thank you. All right, our next comment is from Sandra Tillman. I use data science for social goods Aquitas toolkit. Any other favorite tools?
Can you repeat that again, Rachel, the question?
I use data science for social goods AEQUITAS, Aquitas toolkit. Any other favorite tools that you use?
Oh, okay. Yeah, I actually personally don't have experience with that one, and maybe the panelists do when they come to the panel Q&A. I do think, though, that what helps is having some type of explicit guide or checklist. You know, JC's is one example where you specifically build into the process these different times where you will explicitly stop and think about, are we asking the right question? Are we doing the right thing? Including right up front with that, as the last questioner asked, right, the very first part about program, the goal of what we're doing here. This is not going to be a cookie cutter approach, so that these tools generally will help with some structure and all. But again, there's no substitute for some type of diverse group talking it through and then working through the problem together. The thing again is not a easy solution oftentimes, because you're oftentimes then making choices between what could be some equally good options, where it depends on how you're weighing what the values you place upon different options. That option one might weigh, for example, equity a little more than efficiency, but at a certain point in time, you have to balance off equity and efficiency. So again, these are things where again there's no easy solution, and we think that you have to have these honest discussions with a diverse group, and then when you make a decision for better or worse, everyone has their eyes open of knowing that because we're going for option three, we have decided to prioritize A over B, that value over another.
Okay, thank you. Our next comment is a helpful resource from Tony Solomonides. Arvind Narayanan's 21 Definitions of Fairness talk illustrates many of the difficulties discussed by Dr. Chen, and he provided a link to that article as well.
Yeah, thank you very much. It is a very interesting area. And I think, like, for those of us in this area, I think it's important to have sort of our, in some ways, common sense lay hat on at the same time we have our technical hat on. In other words, I think, for example, it was great that Heather decided to devote a year, of her life to getting additional training in ethics. So she, has a real strong background now in things like distributed justice. At the same time, if you're going to be working this field in more detail, then I think it helps to learn from, again, like the people like Sasha and JC and Heather, some of these technical definitions of fairness. And ultimately, again, like, this wider group has to think about integrating the two of, these lay definitions of distributed justice with these more technical definitions, because the both have to be sort of integrated, and that's going to come to, like, the most informed decision.
Thank you. And lastly, our comment is from JC Rojas. The model intended to find patients who could be discharged within the next 48 hours. This is piggybacking back to Susan's comment. Predicting long length of stay, as it turns out, is harder from modeling point of view.
Just thinking,
yeah, I have a little background, Marshall, on this sort of specific question. I think when that sort of specific project kicked off, there was an intent, obviously, by the health system, like every other health system out there, to sort of think about how can you move patients who are ready to be discharged through the walls of the hospital into another care setting, whether that be home or a skilled nursing facility, et cetera. And I think in that endeavor, one of the things that the modeling team settled on at the time was, can we sort of figure out who is most ready to be discharged in the next, say, day or two? Was the modeling approach taken? And in doing so, that's sort of where some of the biases that you mentioned were uncovered. And I think, obviously, to I think the question that was posed, I think people are really trying to figure out, when someone arrives to the hospital, obviously people who are going to be there for a long time, can we get them some resources potentially to sort of truncate or shorten that length of stay in some way. That being said, I think those patients that sort of form the tail of the length of stay, I think, are harder from, like, a data science point of view to sort of accurately predict.
That's a great point, JC. Again, I just emphasize that again. The intentions were very well. There was well-intentioned, and it's an example of, like, how insidious it is, and so that unless we front and center and always are aware of like these sources of bias, and then again, better yet, what can we do to intentionally advance health equity? This is a lot of ways that things can go wrong in this algorithm life cycle. So those are great questions, and maybe we should turn to the panel, and because I think there's probably a lot of wisdom that we need to hear here from the panel.
Awesome, thank you. Go forward.
Very good. Well, on that note, thank you for a really superb lecture and overview of this broad and exciting new frontier for informatics and for all of us. Marshall, really great. Thank you. I'd like to now introduce our expert panel. And we are really delighted to have these three panelists. Dr. Sachin Shah from is an associate professor of medicine and chief medical information officer within primary care at the University of Chicago. Dr. Heather Whitney is a research assistant and professor of, I think, research assistant professor and professor of radiology also at the University of Chicago. And Juan J.C. Rojas Dr. Rojas is assistant professor, Department of Internal Medicine in pulmonary critical care and sleep medicine, and director of clinical informatics and data science in the Department of Internal Medicine. And then for the Division of Translational Medicine Research at Rush University. So everyone here is wearing a number of hats and are really our worldwide experts in this region. So really delighted to have you join us. Thank you very much. There are 4 questions that are discussion questions for the panel, and panelists can volunteer to speak first. There's no particular order. I'm not going to single anybody out, but the first one is based on that presentation that we just saw. How can we implement results from this research to advance health equity in our health systems? And we have 3 health systems represented here. Much of this may have been addressed by Marshall's presentation, but keeping in mind, you use Chicago Medicine, Rush. What are some of your thoughts?
I guess I can briefly start. I guess the question, I guess the best answer to that question, I think, is really thinking about how can you have health equity be a pillar of a larger governance structure. And some of the work I did when I was at University of Chicago and now doing at Rush is sort of better understanding national trends around AI governance at health system levels. And so some kind of data that we published a couple of years ago and are doing some follow-up work now is sort of saying that, even among high-performing health systems, the best estimate is around 60% of those health systems have some panel or person or group sort of having an AI governance policy, of which potentially health equity is one key pillar of that. But many other health systems have either limited resources, competing organizational priorities, or no sort of guardrails or governance structure in place such that equity could even be a pillar. And so I think the first thing is sort of acknowledging that I think with the emergence of these technologies, there is a lot of promise and hope. And then I hope that we can really move the needle from a variety of different angles. But I think in order for that to happen as safely and equitable as possible, I think there needs to be a combination of, like Marshall said, a collaborative working group that has different hats and skill sets, kind of thinking about the problems and then picking the right AI solutions for that problem, and then making sure that in doing so, there are no unintended consequences, even if you are well-intended at the beginning. And I think, that first step is like, do we have a process in place to do that? And the answer is that many health systems still no. So I think that's the first step, is acknowledging where to start and then sort of building upon that.
Yeah, I can add on to that. I completely agree, JC, with how you're, framing that. I think from my perspective, I spent a lot of time on the sort of the implementation side and the clinical side and the operations side of these tools and these technologies. I think there's perhaps a temptation, and certainly an incentive from the industry side and from the vendors. JC, you were talking about, there's a lot of the sort of direction to go with this. There's a lot of solutions out there looking for problems, and they're proprietary solutions, and they actually run counter, like Marshall was saying, to what we in fact need to demand if we're going to be focused primarily on health equity, which is the transparency. OpenAI was open until it wasn't, right? We don't actually know what a lot of these proprietary models and these, increasingly these large language models that power things like ChatGPT, and there's integrations into our large electronic health record vendors, and there's out of the box models that are available. And that's tempting, right? For health systems that maybe don't have the infrastructure, or that don't have maybe the skill set or the resources to to develop their own, and even for those that do. And I think we've seen time and again, and JC and I have worked on this here when he was here, and validating some of these out of the box models on our own patient population, showed us that they did not perform well at all with our patient population, which was probably very different from the population that the model was trained on. And so part of this is a plug for, to the extent that we can, develop our own models, because we control the incentives. Like we control like the design, in our focus is, what it can and should be on the North Star for all of us, which is, patient care, equitable patient care, and equitable patient outcomes. And if we do, deploy some of these models that were developed elsewhere, we have to demand that transparency, and we have to validate it on our own population. I think that's a really good place to start, and then make it generalizable. That was another thing that was, referenced in Marshall's talk, is, not everyone has these resources, but we should be able to help support other places to deploy this, and to do it, in a rigorous way, by making these principles and these approaches generalizable, not only where we validate it, but elsewhere.
Those are all really great points. Oh, I'm sorry.
Oh, no, I was just going to segue to you and ask for your thoughts, especially on radiology reads and AI and a whole range of things, but also on the systems issues.
Oh, thanks. I'll just maybe add a few points to complement what's been said. And I think they really just join the previous points together. Something that we think is really important is to bridge from, the big picture, big governance, hypothetical scenarios, walking algorithm use down to what actually happens when a physician's sitting down with a piece of information for just one patient. So it really requires kind of big thinking, drilling down to small thinking, personalized thinking. And I think one way that can be facilitated is, if a health system can sit down and maybe walk one task, one tool through all the way down, what's the governance? What are the principles behind it? How does that information actually go into the model? How does the physician interact with it? Walking through one use case could really be productive for informing all stakeholders, for setting those models of what happens, for raising questions, going back to developers, all sorts of good things. So I think that bridging from big to small level can be really important for health equity overall in systems.
Can you first put the panel, what's the relationship generally like with IT? So outside of the CIO office, but with the actual IT infrastructure and the leadership, have you found there's been an openness to working together on addressing this issue?
In my role, I interface a lot with the IT team. So I can start. I mean, the short answer is yes. I mean, I think when we struggle sometimes is when there's a lack of direction given to our IT colleagues. It's also a results-oriented business, and there's a ton of demand on the time, and there's a lot of I think there's a lot of pressure to just get things done and get them out. And again, the temptations I sort of alluded to earlier, come into play here. But if there's engagement and there's direction at the clinical and operational leadership level, and if there's a commitment, to JC's point, that health equity is a pillar of your strategy, and it's a priority, then yeah, with the appropriate partnership and guidance, which is I think what it's certainly here our teams look for, our IT teams look for and value, then yeah, I mean, I think you move forward with these sort of central kind of priorities in mind, and get, yeah, I think you can get much closer to it.
Mm-hmm. It sounds like that's been your experience, JC, too. In fact, it's been kind of your team model that seems to be driving that.
Yeah, no, I would just echo what Sachin said. I think in my previous time at UChicago and now my time at Rush, I think working with the IT leadership, from the CIO down to many of the people that report to, that person's office, I think there is a acknowledgement that equity should be a part of how we assess vendor and or homegrown built analytic tools. I think this interesting space now, I think, is kind of segueing from what Marshall spent a lot of time talking about, as sort of algorithmic fairness for what some people call sort of AI 2.0, right? So like that was sort of the idea that each AI model had sort of a trained task in mind, so predicting length of stay or readmission. Now we're sort of moving into this new frontier where one model potentially could have a lot of different applications in the case of, any of the large language transformer models, and sort of doing a lot of different things, right? And then I think then it's maybe a little harder to go underneath the hood and sort of figure out some of these sort of fairness concepts that we thought about for a long time with sort of a binary yes/no outcome, or an outcome like length of stay, where how do you sort of assess equity as it pertains to words that someone are sort of getting drafted in a patient message, or a documentation that is being summarized for a clinician in the hospital around what happened to the patient in the last 3 days or something, and I think that's where we will have to think about how do we include not some of the important things that I think we're going to keep on predicting, which are sort of these kind of AI to sort of pick each healthcare problem for one specific task, right? Predicting mortality, predicting length of stay or something. But then also, how do you incorporate equity as to the governance structure to something more complicated in some ways, which is sort of the large language space, which I think is sort of another evolving frontier that I'm definitely hearing with colleagues across the country in this space, is sort of how do you, that's like a whole new kind of, I guess, silo to worry about, if you will. And so I think that's something that is a moving target.
Yeah, and with these, and it's a great point. I mean, these probabilistic models, I mean, you can ask the same question twice and get two different answers. And if you don't have some of that transparency around, okay, how is this trained? Which in reality, I think we're not going to have. I think, let's be realistic, unless we develop, our own LLMs, or medium language models and small language models, which is a different topic. Maybe we can get to that in a little bit. But I think the response to that then has to be in that sort of accountability and that monitoring sort of phase, and we have to look at the outcomes that these interventions are driving, and very specifically through that equity lens. And so we have to be very vigilant about the outcomes that we're seeing, and then find ways to mitigate that, as Marshall has talked about, and both JC and Heather's frameworks, published frameworks have very in a very detailed way sort of accounted for and called for.
Thank you. And Marshall, I put a comment. I was recently at a conference about equity issues for persons with disabilities. Biases in the medical record affecting eligibility for disability was a major concern. I guess it's kind of related to your comment, Marshall, and feel free to unmute and join the conversation directly if you'd like to, of course. But Heather, so when I did my PhD, I did a neuroimaging work, and I remember using MNI coordinates of the brain to map signal at that time, and it was based on the brains of 100 white French Canadians in Montreal. And it just occurred to me that across the board with imaging interpretation, that whatever standards there are, reference panels, I have no idea how this applies to, say, reading a breast MRI or a mammogram, and whether there's potential for bias there too. What are your thoughts about digital imaging?
It's certainly a concern, and I think it's important to note first that when new emergences of research options were available, it's very reasonable for a starter data set to be very small, right? But the main thing is knowing that data set's small, and knowing what its limitations are, and knowing what its limited representation is. So as you mentioned, this data set that you worked with, it seems like you were aware of its limitations. And I think that's something that going forward, we need to always keep in mind as new research areas are emerging, the importance of reporting different characteristics and attributes. Even if one thinks it's not important for the research question, it's important to have that there and open and available so other avenues can be pursued. But this is an interesting question of do physicians, when they interpret images, Do they have a kind of bias, either kind of explicit, they've seen perhaps the race characteristic of a patient that enters into the decision-making process, or if is it implicit? There's some studies that suggest that, for example, body mass index can introduce some bias in interpreting images. And it's unfortunate we don't have a clinical colleague here in radiology, because I certainly don't want to speak to the specifics of the clinical practice of radiology. But from our understanding of reader studies, we know that those things can enter in. And I think this is normal that these biases exist. And then the main thing is to get a handle on them and measure them. So one thing I would emphasize is the importance of reader studies. They are limited. They're not, a direct clinical translation, but they help us get an understanding of what are we working with behind the scenes. And then that can feed into what steps can be taken to address them.
Okay, thank you. So I'd like to then segue into this. How can we implement results from this work to advance health equity in our communities? So going outside the health systems, from many of you thoughts, including Dr. Chin, how to go outside our health systems, and how could this transform the way we approach communities and engage them, and even recruit for screening tests and things like that. Does algorithm bias play a role?
I would like to share my really positive experience with kind of incentives in different programs for building these kinds of collaborations. So I recently applied for a grant that was really incentivized to work with a community advisory group, and I had never done that before. And even though we didn't get the grant, it was such a wonderful process and so instructive for me to meet with this potential group, to share with them our ideas. They were excited about the possibility. And the thing I want to emphasize is sometimes, joining with such groups, you don't have a planned outcome. And that's part of the goal, is to be creative and open and ask questions and learn from each other. And so I personally feel very excited about the role of these open-ended community groups from all kinds of stakeholders and what they can achieve. I think they're really important for achieving health equity in the community based upon what they can provide together.
That's a great point. I think that comes out in our I-Core or design thinking types of approaches of co-creation, which maybe they're not developing computer algorithms, but they're developing population health prevention algorithms, which then of course involve computing and other things to do the kind of survey work we need to do in mixed methods. So yeah, it makes sense. Other thoughts on community?
Yeah, I mean, I think the way I think about this from a community point of view is just sort of twofold. One, I think, is increasing and enriching the data that we have access to that inform these tools, right? And I think the more that we can make the data that we use more diverse, when that could be, health system data, imaging data, whatever, omic data, whatever it might be that goes into these data streams, having it represent the patients that we serve and care for in our community, I think is, one way. It's not perfect. It's not going to make algorithmic bias go away, but certainly will make it easier for us to have a better chance at the beginning when we start on thinking about different solutions and problems where AI could be a use case. And then I think to sort of Marshall's point and some of the work that we did in the paper that was on with Marshall, we sort of thought about, how can we actually start thinking about engaging, patients that we serve, as far as not so much maybe what data to put into what features to put into a machine learning model around, say, mortality, but rather how would you actually, in the case of a use case that we had at UChicago and now at Rush around palliative care, how do we communicate when a machine learning model actually predicts that you might die, for example? And how do we message that in a way that it makes sense to patients? Also making sure, what is that? Because most of these tools still have an efferent human intervention, right? We're asking a doctor or a nurse to do something, or a case manager to do something. And they obviously have the ability to, usually because they're the human in the loop, to sort of say yes or no to that nudge, if you will. And so how do we incorporate, what are the best things we could do for you as a patient if it's around, any use case that could be kind of fill a gap that you have as far as your health. And I think oftentimes we in the healthcare system are thinking about, okay, well, if it's a tool for this, then the approach should be we should, prescribe that for everyone. But maybe for different patients, that thing should be different. The cocktail of interventions might have to be different for different groups of patients, as assuming that people may have different needs of where they are, right? So I think that's where having more active community engagement that could be kind of a voice in the room and part of that transparency and governance structure around different use cases and needs to sort of be like, a sounding board, if you will, for different ideas that are going on that we hope will impact your health outcomes in a positive way, and we hope will mitigate or at least not exacerbate current health inequities. It's sort of a sounding board. I think I don't have that. I wish I did. For a lot of the ideas I have, I just assume that, I have to sort of run it by a few people to sort of get their face validity, but I have no patience. I could sort of hit like phone a friend and have a meeting, once a month on sort of some ideas that are going on across our health systems. But I think that would be a really fruitful way of engaging the community and making them feel part of the process.
I completely agree. At the design phase, I think it's an opportunity for that engagement. Just like JC said, I think it also gives us an opportunity at the more distal in that process where if and when we are using these tools to set an example and to actually change the narrative a little bit with our transparency, and leverage that explainability that we're also calling for, and say, hey, as part of this, decision, making that's shared, I've used this, this particular tool, and this is the goal of that tool, and we've recently developed it, and here's kind of what goes into it, and here's what we're hoping that it's achieving, and being very transparent about that. We, in healthcare historically, we have not been transparent about, a lot of things, and we've earned this degree of mistrust, over time, especially with some of our most vulnerable populations. And it's our, it actually gives us an opportunity if we take it to sort of change that narrative and change the trajectory of this by actually being very transparent about, how and when we're using some of these tools. And and again, if you combine that with what JC was just talking about, that engagement early on in the design phase and all the way through, I think we have an opportunity to shift things.
So thank you. I was just thinking about a study that we just got funded from NHGRI on pharmacogenomics, and it's predicting hospital readmissions in 90 days based on adverse drug reactions related to a gene drug interaction. And it's going to be using MetaMap to use NLP to do searches of ER notes, basically, to pull things out and then link them to an FDA database. But it occurs to me that MetaMap structurally, and maybe the FDA's database of side effects, that there's lots of areas for bias to creep into that process and maybe under detect or over detect. And I wonder what your thoughts are about how our team should approach this thoughtfully. We're working with some informatics experts at Vanderbilt, University of Chicago. So we have plenty of experts on the team and some diversity in the team, but it just seems like there's potential to even there to overcall or undercall attribution to a readmission based on what's in the plain text and large language, but also the structure.
Yeah, this is one of these points that I think is really important to come up. The first one is moving forward, when we have this information, it's been a decade and a half now that most people have been on EHRs at least. And so we have this treasure trove of clinical information in these health records and in notes in particular. And you talk to some people outside of healthcare, especially in sort of this entrepreneurial space. And the assumption often made is that, hey, the information, the data in the EHR is really good, that's it's right. If it's something that, a provider wrote in their note and signed, and Marshall's smiling and JC's smiling, Heather's smiling, but it's not right. I mean, there's a lot of, unfortunately, there's a lot, the way, this was like the original sin of the EHR, the way that it was deployed, is very burdensome. It leads to a lot of templated copy and paste, and frankly, a lot of mythology, in these electronic health records. And if we're using these electronic health records to train, models and LLMs, and we expect it to to be a step forward. We actually have to take a step back and consider what's good data and what's not good data in the HR, and that takes effort, because it's not altogether straightforward in any way. And then the second part, though, is we sometimes struggle with the standards that we are applying to some of these new sort of tools and new sort of developments. And this standard is sort of this ideal, this perfection. It has to work perfectly. And the point I think to be made too is that our current state is nowhere near that. I think part of what we want to drive towards is improvement and incremental progress. You think about the self-driving car kind of controversy is like, oh, there's one accident, and it makes the news. But hey, what's the accident rate in the current state? It's much higher. And I'm not like a proponent for self-driving cars, but the point is that we have to compare it with the current state, right? And I think we have to talk about sort of the incremental progress, as long as we have these controls in place, like this vigilance, this monitoring, and this commitment to continual improvement by mitigating the reasons that we find for the underperformance, and we sort of keep striving towards that continual improvement, which is the very essence of a learning health system, and which is, I think, part of what we want to apply to this. So I'll just say those two things.
Yeah, and also Sandra Tillman's comment is really helpful here. This 3 key informed interviews with local environmental groups changed the data we add to the social data comments. So I just came back from a design thinking boot camp in Silicon Valley at Stanford, where we would go out and prototype something that was cheap, fast, and good on some design idea, and we could just interview 5-6 people and learn quickly what works, what doesn't, what resonates, what doesn't. But at least it would stop us a much more expensive, time-consuming failure later. So
yeah, I think we got to be willing to. Yeah, I mean, absolutely. I think you got to be willing to succeed or fail fast and move on.
Yeah.
That's the pace of this. Doesn't necessarily, I mean, practically speaking, doesn't necessarily allow for us to ruminate on this and try to find the perfect, sort of version of this, before we deploy anything, because we'll be left behind, months ago, years ago, if we do.
Thank you. So, because we're closing up on our time fairly soon, I want to make sure we at least address policy. And Marshall, in particular, I know you've been very active in policy. But this could pertain to funding, it could pertain to regulations, a whole range of things. So any thoughts on what the administration does next, or what we should advocate for with policy?
This is one of those complicated areas where there's a lot of different stakeholders that all have a role. So we've talked a lot about, like, at the level of our organizations, the intra-organizational policies that are necessary. That's clearly an important level. When we're talking nationally regarding things like regulations and all, then it's a complicated cast of characters, right? So right now the FDA has some authority over some of the algorithms and all. The professional associations are trying to come up with different standards on things. I mentioned like the Europeans, so that's a good example to look through of they try to balance like safeguards and regulations regarding equity and patient protections with allowing enough creativity for the free market to do its thing regarding innovation. So some tricky issues there.
But it's exciting to see where the impact has been from the work that your panel's been doing already. So I think this last question is, how can we implement results from this research to advance translational science? And I printed out that figure from your JAMA Network Open paper, that bullseye figure, because it's great. And I want to think about that every day as I would go into different stages of development and implementation. But as a translational science competency area, this seems like this would fit nicely into that rubric that NCATS has, but also where are the gaps, the evidence gaps in this field where you'd like to see the science go next?
Yeah, that's a great point. I think one of the things that Sachin just said is so true. I think there's this tension in healthcare, especially on the operational side versus the research side, in the sense of the AI technologies and AI kind of pressures as far as like using it, quote unquote, and this is in air quotes, using AI, versus, testing AI and seeing if you can add the rigor to it to sort of see if you have time to really see if something like a clinical decision support nudge based on AI actually makes a difference for some meaningful patient-centered or health system outcome. Those tensions exist. So I think the key here for translational science, or just science in general, is picking the right AI solutions that are worth the time and rigor to study, right? Like maybe if you're sort of operationalizing a model, let's sort of think about, say, keeping your MRI machine very busy. Maybe that's not the right one to sort of say, okay, that's the one we're going to die on as far as our scientific rigor to sort of study. But if it's something that maybe that might, say, address social determinants of health at scale at your health system, maybe you should have a sort of a rigorous design that's a little different than the typical pre-post that usually is done for sort of these type of projects, where you might want to think about some way where you could maybe randomize an intervention and sort of see if this AI-based algorithm or nudge that usually is AI plus human doing something to really impact something meaningful, and sort of see if it does. I think that's where I think a lot of the AI literature is moving, is I think we're moving away from, hey, we built something cool, to, hey, we built something cool and we used it and it did something cool, and I think, but for the many kind of few years where I was working in the AI space, it was like, oh, it was good enough to just say we did something cool retrospectively, but we never turned it on, and then we don't know if it will work. I think the days of that are sort of going away, for better or for worse.
So I just had this idea. So we have this community stakeholder advisory council that was really developed, well, I say we collectively, but under leadership from Dorian Miller and Albert Wong, Elizabeth Lynch, and so forth. Really, it represents a broad swath of Chicagoland diverse CBOs and faith community and so forth. But if there could be some cheap and fast prototype testing on AI where you really don't need to have a new algorithm, but it could be a description, some, it might be a cartoon or not, or some visual description of what if we did this? What would we be missing? Would we be hitting some things we've missed in the past? That rapid testing approach that starts with code design on the front end, could that be a study to see how well that performs? And so anyway, any other comments on translational science before we?
I would just like to comment. I think this is relevant from a comment by Anthony Solomonides here. He mentions the tension between innovation and regulation. And I do want to highlight MIDRIC, the Medical Imaging Data and Resource Center, that published the paper that Marshall so kindly referenced from us on bias awareness. A really nice feature of it is that we collaborate with people from the FDA, on ground zero on the research questions that we're having. And the whole goal of MIDRIC is to accelerate the translation of AI algorithms in medical imaging to clinical use. And so I think bringing on board collaborations with regulatory scientists, especially at the FDA or otherwise, is really important for this translational question.
Thank you. That's a great point. And I think we're at the end of our time, but Rachel, can we advance to the next slide here? So I just want to say to everyone, thank you so much for your contributions. This is so above my head in terms of the informatics and a lot of the technical issues, but it also makes intrinsic sense that that this reaches to programs we use every day that we don't even see quite use. And is having a framework like this and multi-stakeholder team will make is hopefully how we move forward. And thank you, Heather, for your comments on MIDRIC, and the link is there. For any questions, comments, requests to present at a future seminar or ideas for topics, please contact me directly. Also, there's going to be an evaluation that Rachel's going to send out in an email to participants to fill in. We do value your your comments, your feedback. It has helped us over the last 4 years of this seminar to get your comments and your evaluations. And then this is being recorded as well. And there's a link to our YouTube page where sometime by tomorrow, I think we'll have this posted. Here it is, that link. But again, I want to thank everybody for your participation. And this is really an all-star cast today, but such an important topic. And thank you all for bringing this to public's attention and for really developing a new field of science around this work. So thank you so much.
Thanks for inviting us all to participate. It's a lot of fun.
Thank you,
Thanks, Marshall.
everyone.
Thanks, Sachin.
Thank you.
Heather,
Thank you.
JC.
Bye.
Thank you. Okay.